So I'm going to talk about using big data to help us make better decisions, and in particular thinking about how we can harness and utilize advanced analytics for policy relevant health insights. Before I begin, I'd just like to thank some of my team, Nithya Lango, Jim Rafferty and Tim Osborne, who contributed to this work. And I'd also like to thank our funders and the data providers who make anonymized data available for research, without whom none of this work would be possible. So I thought I would just start by, what do I mean by big data? Well, in this particular talk, I'm going to be talking about utilizing the SAIL databank, so the Secure Anonymized Information Linkage Databank. Now, the SAIL databank is hosted by Swansea University, and it is an individual level, population scale, anonymized linked electronic health record for the entire population of Wales. So what this means is that at any one point in time, we have around 3.2 million people with their entire linked health record, and we have 25 plus years worth of data. So as you can imagine, that people move in and out of Wales, so this number, this 3.2 million, increases substantially when we look over multiple consecutive years. On the right hand side, you can kind of see the types of data that we collect and that we link at the individual level anonymously. In the grey diamonds here, we've got demographic and mortality information and things like education and social justice information. In the dark blue, we have disease-specific data, things like cancer registries, cancer screening, cancer treatments. There's also the MS register, which you could link in to the SAIL databank. In the lighter blue, we've got secondary care information, so hospital data, including critical care and intensive care, outpatient appointments, emergency departments, and in particular, diagnoses that were made in secondary care settings. And NHS 111 data and general practice information. And we can also get some lab results, things like blood test results, histology results, and so on. And all of this is at the individual level, but we can also link to a residential level, which is also anonymized. So the residential anonymized linkage fields allows us to identify where in Wales people live, and it can help us to look at environmental impacts on health, things like access to green blue spaces, distance to healthcare services, and so on. But we also know periods of time when individuals have lived together, or things like care home residencies and so on. So we can start to look at household dynamics within the home and how this impacts on health. You can also bring in a custom data set to Wales, which is de-identified and linked. So if you wanted to collect particular information and wanted to link this to longitudinal health records, this is also a possibility where governance is confirmed to do so. And what this means is that we get very rich data on individuals. So imagine this is one person, and it's just a made-up person for the purposes of this presentation. But what I can see is over their life course, I can see when they've attended things like emergency departments, how long they've stayed in hospitals, tests, treatments, diagnoses that they've had. We can also follow them up with outpatient appointments, which medications they've been prescribed, what their lab results were. So how is their severity of disease perhaps looking, and particularly for things in like diabetes, like HbA1c, for example. We can link it to cancer screening and registry. So have these individuals engaged with cancer screening? What were their outcomes? And so on. And of course, as I mentioned, we can also look at periods of stay in care homes and so on. And we can link this all the way up to the end of their life. And we can also look at things like cause of death and so on. Now, this is just for one person. And as you can see, it's a very rich data set. But we have this for everybody who's contributing data to the SAIL databank. And there's around 85% of GPs who are contributing data anonymously for this purpose. Okay, and what do we mean by advanced analytics? Well, in this particular talk, I'm thinking about policy relevant research. Now, this often requires probability statements, things like, what is the probability that one treatment is better than the other? What is the probability that we will improve outcomes for patients and the NHS if we were to implement a new service, for example? The other thing that we want to do is to be able to capture full parameter, and by that I mean the uncertainty in our modelling approach and the uncertainty in our data. So in Wales, we've got a heterogeneous population that we want to capture, and that populates through as uncertainty in the data. And for decision making, we want to capture all of these uncertainties. And I'll demonstrate this a bit later on, but we all often want to capture complex relationships when we're thinking about policy relevant research. And for this, we need often flexible shared parameter frameworks. And I'll give you an example for you to get a feel for what this looks like later on. But these three things lend themselves to using Bayesian methods. And now Bayesian methods are increasingly being used by decision makers. NICE have been using them for a very long time. MHRA have recently published some guidance on using Bayesian methods and a move towards that. So these methods are not new. And actually modern Bayesian methods, and by that I mean post-computing era, they are typically implemented using simulation-based approaches, things like Monte Carlo methods, simulations. And these are particularly helpful for when we want to fit these complex models. But in general, when we're dealing with very large data sets, very large in terms of the scale, so the number of people, the number of rows that we want to model, but also the number of things that we might want to feed into that model, so the information, the variables. So that's the dimensionality aspect. These simulation-based approaches often become intractable or infeasible when we're dealing with this very, very large population scale data. So what myself and my team have been working on is fitting some hybrid models, and this is utilizing some machine learning approaches, which allows us to optimize this problem. And I'm going to show you this very visually, and I'm going to walk you through, there are some equations or notation on here, but I'll walk you through the process in more lay terms. So imagine you've got this distribution that you want to estimate. This is what we call our posterior distribution. And for lots of reasons, as I mentioned earlier, this is very complex for us to estimate when we're working with large data. Now, this blue circle here represents all the possible distributions that we might want to be able to capture. So this can take any form, any shape. Within that set of distributions, we have another set of distributions in green here, which represent a family of variational distributions. And these distributions are ones that we can define. And by that, I mean there are a set of parameters. We call them variational parameters that we can specify that will tell us what this distribution looks like. And you might want to combine different distributions using some complex relationships as well. And effectively what stochastic variational inference is doing is it's finding the optimal set of variational parameters that sits as close as possible to the distribution, this posterior distribution that you want to estimate. So we want to minimize the distance or the divergence between these distributions. There's lots of ways that you can do this. One way is using the Kullback-Leibler divergence, but there are others. And in utilizing these types of advanced analytical frameworks, it reframes our simulation-based problem into one of optimization. So we're now optimizing these variational parameters, which allows us to fit these models to very high scalability and high dimensionality data sets. However, they are an approximation. We get as close as possible, but we're not sampling directly from that distribution. So it comes with all the caveats of standard approximation methods. We need to do lots of testing and lots of sensitivity analyses to check that we are happy that it's as close as possible. Okay, so I'm just going to walk you through two case studies where we effectively use this type of framework, fitting these advanced analytical methods to large-scale data. And the first one's going to look at multiple long-term conditions. So the question we wanted to answer was, how can we identify clusters of long-term conditions that result in higher mortality? So what we want to do is condition on an outcome of interest. So for those of you who are analytical, here I'm talking about supervised learning. But within these individuals who live with multiple long-term conditions, we also then wanted to look at how medications cluster, conditioning on medications related harm. So which clusters of medications do we see a higher probability of medications related harm? Now we want to use these advanced methods, we want to use these Bayesian frameworks because we need to incorporate this flexible shared parameter framework. And I'll touch on that a little bit later on. But I just wanted to quickly go through what some of the common pitfalls in standard clustering methods are, particularly when applied to large-scale data. Now, when I'm talking about standard clustering methods, I'm talking about things like k-means clustering, hierarchical clustering, or latent class modeling. And these types of approaches, which you'll come across fairly often in the literature, they rely on these unsupervised groupings, so these unsupervised clusters. So what it's doing is it's looking at the similarity in the predictors. So in this case, we might be looking at the similarity in how many people have combinations of multiple long-term conditions. What it doesn't tell you is then how that influences the outcome and whether there are clusters within those groupings that are different when we condition on an outcome. They often require fixing the number of clusters, whereas a Bayesian approach can take a data-driven approach and learn from the data in terms of how many clusters there are in our data set. And they often assign people to individual clusters without accounting for the uncertainty in that cluster assignment, which again, for policymaking is really important for us to know how many people does this impact and so on. So accounting for the uncertainty in assigning them to these clusters is super important. And when we apply this to large scale data, there's often a lot of data pre-processing that's required, particularly in terms of dimensionality reduction, so reducing the number of predictors that we fit in these models. And for all of these reasons, these types of approaches are perhaps less relevant for epidemiological research and or to inform policy. So what we use is something called Bayesian profile regression, and this, I'm going to quickly walk through how this works, I guess. So using a very simplistic example. So on the right-hand side, we've got socioeconomic status on your x-axis, and you've got educational score of these individuals on your y-axis. Now imagine that we don't know how these individuals cluster. So you can see that they cluster quite nicely in this example, illustrated by the different colors and the different slopes of this model line of best fit. So our job is to try to identify how these individuals cluster, conditioning on their educational outcome. But we do know some other information about these individuals. So we might know things like the latitude and longitude of where these individuals live. And we can use this to learn about how they might cluster together. And it's unsurprising here that actually these clusters are representing different schools. And you can see that perhaps those of a very high socioeconomic status have a higher educational score, and they also tend to cluster within this purple school here. But what it means is we've got two models. We've got our mixture model, which is our model where we're putting in the latitude and longitude of where these people live. And we have a response model. How do these clusters impact on the educational score on the right-hand side? So what effectively we've got here is a shared parameter between these two models that we want to estimate. And we want to learn from both of these models at the same time. And of course, we've got a nice hierarchical structure to our model because of the way in which these cluster. So these all lend themselves to this Bayesian framework. But in our particular case, we're interested in multiple long-term conditions. So we might put in our mixture model the probability that an individual has cancer and cardiovascular disease. But of course, when we think about all of the multiple long-term conditions that we might want to feed into this model, we're not talking about a two-dimensional space or even three-dimensional space here. We're talking of a very, very high dimension, which is why we require these approximation methods. So we fitted this to the Wales Multimorbidity E cohort, and my colleague Jane Lyons curated this cohort in 2021. And she was able to link demographic and mortality and health records for 3 million individuals who were alive and living in Wales on the 1st of January 2000. We applied this particular framework to adults only, and we included a 5-year clearance period, meaning that individuals couldn't have been diagnosed with any of the conditions we were interested in within that 5-year period. And this was to ensure that we were getting their first diagnosis of these conditions. So once we applied these restrictions, we had 1.3 million people over a 20-year period. And I'd like to credit my colleague, Jim Rafferty, who's working within my team, who helped to develop and apply these models to the case of multiple long-term conditions. And we fitted this to 29 long-term conditions, which are defined by the Elixhauser Comorbidity Index. And these models were adjusted for age, sex, and deprivation. And when we fitted these models, we actually identified 33 different clusters when we conditioned on mortality. And what you can see here is a heat map of the results, where navy is a 0 probability of the disease and a 0 probability of mortality, and yellow is a probability close to 1. The first 2 rows are your outcomes, so this is mortality for females on the top and males on the bottom. And you can start to see how the probabilities of the diseases increase as the probability of the outcome increases, and their combinations. So the cluster with the highest probability of mortality was actually a cancer and metastatic cancer cluster, which is perhaps unsurprising. But what was surprising was that we had a number of clusters that were metastatic cancer and cancer clusters. So let's take a deeper dive into these particular clusters and put them side by side so we can compare them. So we can see that our highest probability cluster had cancer and metastatic cancer, but they actually had a relatively low probability of all other diseases in this particular example. And when we look to compare that with the other cancer clusters that we identified, we can see that actually the other cancer clusters had a better prognosis in terms of survival, but they also had a higher probability of other diseases. So we were often seeing cardiovascular diseases, things like hypertension. We were seeing a higher probability of renal failures, diabetes, and so on. So one of the things we think might be happening here is that we're identifying a perhaps treated cluster who may be experiencing the cardiotoxic effects of some cancer treatments. And unfortunately, in our higher risk cluster, these might be an untreated population. This might be because we identified them at a later stage in their cancer trajectory, and therefore the treatment options might be more limited. And remembering that these models are age adjusted, so it's unlikely to be related to differences in age in this particular example. So this is really helpful, and it's really helpful for policy and decision making, because if we were to use standard approaches, we wouldn't have been able to differentiate between these cancer clusters. They would have been, I guess, pooled together as a similarity between cancer and metastatic cancer. But because we could condition on the outcome, mortality, and their prognosis, then we can start to differentiate between the cancer clusters that actually have a fairly good prognosis compared to the ones that don't. And we also applied this to the case of medications-related harm, and I'd like to thank my colleague Tim Osborne, who led on this work. And I'm just showing you the results here for the 55 to 75-year-olds who are living with multiple long-term conditions, but Tim has looked at this over different age groups. But in this particular example, he fitted these models to 550,000 individuals And we included 135 medication groups in our mixture model. And these were defined using the anatomical therapeutic chemical classification. And again, these models were adjusted for age, sex, and deprivation. And what we found when we applied these models is that there were 17 distinct medication clusters that we could find. Now, it's going to be incredibly difficult for you to see these plots, but what I want you to take away from this is that the red rows here are illustrating the probability of the outcome. So the darker, the higher the probability. The green row here is the size of the cluster. So actually, the majority of people where we have a larger cluster size actually didn't see medications related harm. They had a very low probability of 0 actually of medications related harm. But what's really interesting is there are some groups of medications that have a nice gradient. As you increase the probability of medications harm, we increase the probability that these individuals are receiving those medications, which are the blue rows here. And there's almost a dose-response relationship where it gets darker as you increase. So I've zoomed in on the ones that are these sort of higher probability medications. And actually, the combinations that resulted in a higher risk profile included combinations of drugs for peptic ulcer and gastroesophageal reflux disease, or GORD, drugs for constipation, antithrombotic agents, lipid-modifying agents, beta-lactam antibacterials or penicillins, other analgesics and antipyretics, and antidepressants. And if you look at the last column in this table, these are the individuals that had the highest risk of medications-related harm, and they also had a high probability of being on this combination of drugs. Though I do want to point out that the cluster probability size is very small, so only 2% of this population were allocated to this cluster probability, and they only had a 20% probability of medications related harm. So actually it's affecting a relatively small number of the population. The majority of this population actually had no risk. So there is a low risk of medications related harm when we think about a population scale. But of course, from a policy perspective, this is really helpful to start to understand which combinations of medications may be resulting in harm, and perhaps targeting individuals who might need medications reviews and so on. Okay, so moving on to the second case study where I'm looking at health technology assessment. In this particular project, we wanted to understand or develop a framework to be able to appraise multi-indication or multi-use medication treatments when we're looking at multiple long-term conditions. And of course, here we also want these probability statements because we want to be able to understand what the probability that these treatments are better than standard of care. And we also want to include full parameter, so uncertainty in the model that we're using, and data uncertainty. The full parameter uncertainty is particularly key here because we are incorporating treatment effects that come with uncertainty that we want to populate through to our decision. So just to give you a quick background, health technology decision-making has previously focused on developing recommendations in single conditions. So we appraised canagliflozin, dapagliflozin, and empagliflozin for type 2 diabetes. A number of years later, dapagliflozin was then appraised in chronic heart failure, and soon after that in chronic kidney disease. And I was actually on the panel for the last two of those appraisals. And I said to NICE at the time, you know, people who are living with heart failure and kidney disease and type 2 diabetes, they tend to cluster in that way. So they tend to develop these conditions over their life course. So why aren't we looking at these drugs across conditions rather than just within and just making sure they're cost effective for single use? And NICE actually said, you know, that's great, but we don't have a framework to do that in. So this is where the challenge was accepted. And this work was is funded by Healthcare Research Wales NIHR Advanced Fellowship. Now, this particular approach, looking at appraising them within single conditions, can be inappropriate for people living with multiple long-term conditions because we might not be looking at things like additive or synergistic effects of the treatment across these conditions. And these individuals are often excluded from trials. But more importantly, these individuals also have competing risks. So the development of the next disease in this sequence might alter their trajectory overall and their sort of transition to mortality over the life course that we need to account for. Now, in health technology assessment, we use a measure called quality adjusted life years to measure the impact of these treatments. And effectively, we're looking at trying to extend length of life, but also try to extend the time spent in high quality of life. So there's this trade-off between quality of life and length of life. And as individuals become increasingly diseased or move into more severe disease states, they actually experience a much lower quality of life. So what we want to do is try to delay the time that it takes for these individuals to move into these states and therefore experience higher quality of life overall. So these very much rely on time to event analyses. We're looking at time to death and time to the development of the next disease in the sequence, or how long you stay in a more healthy state. So just some common pitfalls of time to event analyses when we're working with these routinely collected electronic health records data, and things we need to consider in modeling these things. The first thing is accounting for competing risks. So death is always competing with the development of disease or with lots of outcomes that we're usually interested in measuring. But in this particular case, we've also got a competing risk of developing the next condition in the sequence, which might alter your trajectory. We often don't see people accounting for uncertainty in things like treatment effects in downstream analyses, and I'll show an example of that in a bit. And we need to be mindful of things like informed observations. So over time, people who are interacting with their GP service, let's say people who have more observations of blood pressure readings, for example, are going to look different to those who are not getting those blood pressure readings but have the same diagnosis. That might be related to severity of disease and therefore requiring higher monitoring and so on. So if I was to pick that data up as is and just model it, I might get some spurious observations, some spurious associations, purely because of the way in which those observations were collected. So we need to account for the people who are perhaps not having these observations. We need to think about time-related biases, things like immortal time bias, and in particular, how we define time zero. But of course, we often have high dimensional confounding. And again, this is where these advanced analytical approaches can be really helpful. So in this particular study, we first wanted to just identify how individuals accrue these conditions over time, how that might alter their trajectory in terms of the ordering and the timing in which they develop these conditions, and what that means in terms of their life expectancy. So we fitted multi-state models because they allow us to account for these competing risks and these competing pathways to individuals who were living with chronic kidney disease, heart failure, or type 2 diabetes, and any combination. And in the SaIL data bank, in the Wales Multimorbidity E cohort, we had 600,000 individuals who had these conditions or combinations of conditions. And we effectively fit a multi-state model to this. We can take the parameters from that model and we can simulate the case of all individuals moving through this model all the way to the end of their life. So we get a complete life course using individual patient level simulation. And this can give us an idea of what's happening with standard of care. Then we can take effect estimates from randomized controlled trials, incorporating the uncertainty from those trials of these emerging technologies like SGLT2 inhibitors, and we can then simulate a treated cohort and compare how these individuals move through this model. So of course, we want to consider all possible disease and treatment pathways here. So it becomes a very high dimensional data set. And this is largely because there are lots of combinations of treatments that you can use for these individual conditions. And then of course, when you combine them, it can become very large. But of course, accounting for these competing pathways, all the different possible pathways these individuals could take, also increases the number of parameters that we need to estimate. So when you think about using standard Bayesian approaches, we're going to be allocating very, very large matrices that we need to estimate. And for this reason, it becomes very problematic. But for decision making and policy making, we still require these probability statements, and we need to capture the uncertainty in these treatment effects in order to inform our policymakers. So again, we need to use Bayesian. And this is where, again, we're looking to use the stochastic variational inference approach. Now, just a caveat that this is work in progress and these are preliminary findings. So please don't take these to note yet. We need to go through lots of quality checks. But just to give you an idea of the types of outcomes that we're going to get from these types of models, if we think about life expectancy, we actually found that the estimated difference between the new technologies compared to standard of care resulted in a slight decrease in life expectancy of approximately 0.2 years, which was quite surprising to me at the time, because in all of the trials, it suggests that it improved mortality, but I'm just going to come back to that point in a second. When we looked at the development of additional conditions, though, in this sequence, it actually slowed down the time that these individuals accrued further disease. And this is just an example of developing heart failure after chronic kidney disease. On average, it delayed the development of heart failure by approximately 0.7 years. Now, the reason that I think we're seeing a slightly lower life expectancy, though the upper confidence interval is close to 0, so it's only a small difference, is because that actually in delaying disease of heart failure, chronic kidney disease, and type 2 diabetes, which are relatively well managed, there are other competing risks that these individuals are exposed to, things like other disease. So we're keeping individuals in a higher quality of life state for longer, but overall their life expectancy is slightly shorter. Now, speaking to patient and public involvement and engagement groups, this is actually something that they communicated they would prefer. So they would rather have a shorter life expectancy, but in a higher quality of life health state. So actually for our policymakers, perhaps this is something that we do need to consider moving forward, that actually it's not just about their life expectancy. But of course, when we populate this in an economic model, we will be assigning quality of life measures to this so we can get accurate measurements of these quality adjusted life years, accounting for both of these things. So just in summary, so population scale data captures this real world heterogeneity that we're seeing. And this particularly is important because we can capture underrepresented groups that we don't tend to see in research. Things like lower deprivation groups that perhaps are underrepresented in our trials, for example. And this can help to enable policy relevant insights across the whole population. But this is only true if due consideration is given to the modelling approaches that we're taking, and in particular to prevent any biases and to capture uncertainty in our decision-making frameworks. Now, as I hope I've shown you today, Bayesian frameworks are helpful to inform healthcare policy and decision-making, but they do require quite a lot of computational power, particularly with sort of modern Bayesian frameworks. So these scalable computational approaches are required in order to make these analyses feasible on a much larger scale, particularly when we're thinking about working with population scale data sets. And of course, these types of approaches, because they scale quite well and give you estimates in a relatively quick time period, they do have the potential to be used for real-time estimation. So we could potentially embed some of these types of analytical approaches into routinely collected electronic health records, which can help our policymakers, clinicians, patients, and carers to make real-time decision making. Now, the image on the right-hand side here is sort of similar to the one you saw earlier, where we were able to link all of these data sets and how much opportunity that provides. But I've also put in some of the analytical methods as part of this cog, because if we don't get those right, that data linkage and these large-scale data sets are perhaps not as useful as they potentially could be. So we should really start seeing it as part of the whole system.